I'm going to talk about risk factors, genetics, exercise, diet, anticipation, prognosis. But I only have the 5 minutes left. So my thought experiment is, what would I do if I had an unlimited amount of time? And the two of us, maybe with her family also. Maybe she may have children who are worried about it as well. What would I say if I had an unlimited amount of time? And this is what I wrote down in my book, which is titled Unaging: The 4 Factors That Impact How You Age. And by way of apology, the title was chosen by the publisher, so I didn't come up with this idea calling it Unaging. And don't ask me what unaging means. But that was a thought experiment. What would I say if I had an unlimited amount of time? Not only about my recommendations, but what is the biological foundation? My recommendations. Should they really not eat pork? My second thought experiment, similarly, teaching neurology for many decades, I frequently have a situation where I have a class of medical students or neurology residents, and I have them for 1 hour. And I think, well, okay, what am I going to teach? A similar thing happened when I was in Japan, and I had Japanese medical students, and I had them for 1 hour. So I always thought that I don't need to teach the cranial nerves. There are 12, and they're named so and so and so. They do this and they do that, and you can evaluate this one by doing this and this one by doing that. I don't need to teach that. That's all in a book, in many books. And they should have learned it already. And what would I teach them if I had an unlimited amount of time? Or moreover, what is the most important thing I can teach them? What should I teach them that they're not going to learn otherwise? Because regardless of what I think, eventually either they'll learn or they won't learn how many cranial nerves there are. But what about how to respect their judgment? How to deal with the complicated world, electronic health records, and data? And how to think deeply. And this is my second book, which is 99 Lessons in Critical Thinking, which will be published in January. However, there's nothing special about this 99. I could have had 199 or 399 or 45. It's all related, but the idea is by putting them in small buckets, I believe it makes them more teachable, rather than having a big paragraph about a big chapter in a book about critical thinking and a book about memory, a chapter about memory and a chapter about practice. By putting them in as lessons, it makes it more teachable. So I want to teach them what they will not learn, or what they're not likely to learn somebody else. This is the Unaging book, which is available in the U of L, in the Kornheiser Library, and the 99 Lessons in Critical Thinking. So actually, critical thinking is poorly named. It's not especially critical. I think many people think to be thinking critically, you have to be criticizing. That's not necessarily true. It's just rigorous and making fair and careful judgments, thinking about evidence and being reasonable and open-minded. It's something we should all be doing all the time. And my goal is not that I can teach how to think, but just to be aware. The basic, most important idea is to be aware of how you're thinking and be aware of the process of thinking. Be aware that you're thinking and being aware of what bias may have influenced your thinking. So there's a great quote that I could use here if I remembered it, that we all grow up, we know how to do this, we know how to do that. We learn how to open a can of Coke, we know how to use a fork, we know how to think. But we do it all automatically. We don't pay any attention to the thinking process. And that's the idea, that we should think about it. So just in one of many examples, we're all confronted with bias. We all have different kinds of bias. Everybody has some kind of bias. It's not possible to be free of bias. What's important is to be aware that we may or we may not have this or that kind of bias. But by being aware of thinking, it helps us to make progress. And I'll call it a lesson. I don't give it a number because a number would be meaningless, because I don't have time to discuss 99. So one lesson would be to think deeply. In neurology, we often are too lazy to think beyond, oh, a stroke is caused by a thrombus. Or to put it in another way, what is the most important question in stroke? And there's no reason you have to only have one important question in stroke. Of course, there are many important questions. But I'm concerned that many people in this area are obsessed with this idea. What is the treatment window? 3 hours, 4 hours? What about 3.5 hours? Oh, a new study shows actually 4 hours is safer than 3, or whatever the other way. And I'm not implying that this is trivial or that these aren't real questions. Or what's the best stent? Is this company's stent or that company's stent? What has the best outcome? These are serious questions, but they're not the most important question. If you had to say what could be the most important question, my choice is, what's the cause of hypertension? And my goal here is not to convince you that hypertension is the most important question in stroke. My goal is just to think about fundamental matters so that I was at a neurology meeting many years ago, and the speaker on stroke, one of these sessions with 4,000 people in the room at the academy, and this guy said he's glad to work on stroke because at least in stroke, you know the cause. In Alzheimer, we don't know the cause. So I wrote to him, I said, okay, well, I didn't know, what's the cause of stroke? He said, the cause of stroke is thrombosis, hemorrhage, and embolism. That's incredibly shallow thinking. What's the cause of thrombosis? I mean, it's not enough to say, oh, a lipid deposition in the vessel cause. Well, what's the cause of that? Hypertension is prevalent in more than 50% of people over 65. It causes heart disease, and I mean, this is the main causes of death in the world. And I learned in medical school a long time ago, hypertension is caused by stiffness of the vessels, right? Well, what causes that? To say it's caused by stiffness of the vessels is not very interesting. I mean, it's not new. Or we had in our department a very distinguished guy who was specialized in aneurysms. I said, what's the cause of cerebral aneurysms? He said, turbulence of blood flow. Well, I hope I don't have an aneurysm, but I know I have turbulent blood flow. I play tennis, you know, I wake up, I stand up, and I mean, everybody has turbulent flow. It's not like some people are cursed with more turbulent flow than others. There has to be something else. And bacteria can be involved in that, but that's another matter altogether. So thinking deeply and thinking about primary or important issues. In 1955, the polio vaccine was introduced. Look at the fall in the number of cases. This is really incredible. And this is very, of course, this is the time when I was a little boy. And of course, I didn't know it at the time, but you know, I escaped, but it was a big problem. At the time, if you would devote your career to devising a better iron lung, what impact would that have? So I don't mean that taking care of patients is not important and valuable, critical. Yes, it is. But the pivotal question is, what are we going to do about polio? And they fixed it, right? So at the time, in the 90s, I was working in Case Western, and we had 2 enormous grants, NIMH and NIA center grants. And we were working with Kathy Smith, this sociologist, and she wanted to do this study about the relationship between depression and caregivers and the severity of the dementia. And I refused to participate in this because I thought, okay, I already know that the more impaired the patient is, the more stress is experienced by the family. This is a very serious paper in a very serious journal, Gerontology. But it showed that the more impaired the person is, the more stress was experienced by the patients, by the families. And I refused to participate in the study because I thought it was a waste of money and time, because we already know that. That's not the point of research. Research is not designed to teach you what you already know. If you already know it, it's not research. This is just another example of the idea of thinking more deeply. So this German philosopher said, to yield to every whim of curiosity and allow our passion for inquiry to restrain by nothing the limits of our ability. This shows eagerness of mind, not unbecoming to scholarship. But it is wisdom that has the merit of selecting among the innumerable problems we present. Think about those problems whose solution is important. So every research question must be addressed with the idea of what difference would it make? Same thing is true about laboratory tests. If you want to do some test, PET scan, MRI, or whatever it is, consider, well, if it'll make any difference to know the answer. If it won't make any difference, maybe not worth doing. So I'm concerned a lot of research is like mountaineering. Maybe less dangerous than mountaineering, but like mountaineering. They do it because it's there, just like George Mallory said he climbed Everest because it was there. Why did you do this study about MRI of the kidney? And well, had the MRI scanner. And this is a particularly bad problem now because there are a lot of journals which are called paper mills. You have to pay to publish the paper, and the journal wants to publish more papers. And I have published in Scientific Reports, which is published by Nature, which is a very, very serious journal. And Scientific Reports publishes 22,000 papers a year. And as a reviewer, they were encouraging me to accept as many papers as possible, even if the papers were trivial. They said, don't consider the fact that it was trivial. That's not a reason to reject it. And be aware of observational bias. That is, why are you looking here under the searchlight, under the street light at night if you lost your keys in someplace else? Well, this is where the light is. So there is a tendency to apply every new method to every possible problem just because you can. The key factor which determines what happens is our attention. So our experience is not what happens to us. Our experience is what we do with it, or how we pay attention. That's all comes from a quote by William James, the great Harvard psychologist. Do we focus on the patient or on the lab tests? This is a big problem now. Alzheimer's can be diagnosed with blood tests and PET scan. However, this is not the same of what's happening with the patient. So I might have a 75-year-old man who has a memory complaint. And PET scan shows he has amyloid deposits in the brain. So he may be on an Alzheimer continuum because the brain changes start 10 to 20 years earlier. So it may be this guy will get dementia from Alzheimer's if he lives to be 93. Well, he might not live that long. So if I tell him he has Alzheimer's, will I be helping him? Because having the diagnosis is not necessarily meaningful if you can't do anything about it. And this relates to whether the Alzheimer drugs are effective or not, which is another matter that we can discuss another time. But my idea is our focus should always be on the patient, not on the lab tests. Which doesn't, I'm not saying we ignore the tests, but we shouldn't make good decisions without considering the patient's needs. The most outrageous example of this is Janet Woodcock, who was the deputy commissioner of the FDA. She said on the bottom there, we have to just stop thinking empirical evaluation. It's the only way of evaluating truth. We have to stop thinking empirical evaluation. So I looked up empirical to make sure I knew I had the right meaning. Empirical means evidence. She's saying we should stop looking at evidence. I want to say something beepable, but I don't know how to. Evidence is how science works, right? So they approved a drug called aducanumab because it removed the amyloid from the brain, but it didn't help the patient at all. This is not even controversial. It didn't help the cognitive function. And it was the most unsuccessful drug launch in the history of American pharmacology. Focusing on the patient again, my favorite example of this 82-year-old woman came to see me with memory problems, which were mild. And I said, I didn't think she had dementia. And she was leaving the room when I noticed that she had a 3-headed cane and she was wearing high heel shoes. I wouldn't say high, but maybe 2-inch heels. So I said, excuse me, Mrs. Jackson, I'm very sorry, but you're too old to wear high heel shoes. I mean, if she's unsteady that she needs a cane, she needs to have her feet on the ground. She said, oh, Dr. Friedland, I was coming to see you. But my point is, how many people would notice, or how many times did this happen when I didn't notice? You notice what, I mean, it's not in our repertoire, what kind of shoes are you wearing? But this might have my getting her to wear the right kind of shoes may have saved her from falling, breaking her hip and dying. But there's nobody, no drug company is going to come and help us pay attention to the patient's shoes. So this is the idea. What we should pay attention to is not the lab tests. We do yes, we should pay attention to the lab tests, but the most important thing is the patient. This was very beautifully pointed out by this book and all the teaching of Bernard Lowen, who won the Nobel Peace Prize for his role in avoiding nuclear war, but he was a Harvard cardiologist who taught that what is most important, which is being lost nowadays, is listening. And avoid and do not ignore the patient as a human being. And this is already 20 years ago, so it's getting worse. Because of the electronic health record, we are now obsessed with getting to the next patient, completing the note, not getting cursed at night to go, okay, let me see what happened today, and have to write notes on. But what we need to do is pay attention to the patient and consider their experience. So consider your recommendations in regard to the context of their care. So if a patient has unilateral neglect, don't talk to them on their bad side. So I would just make a general rule. Any patient with a lesion in the cerebral hemispheres, you should only talk to them on the better side. If they had a stroke on the right, whether they have neglect or not, don't talk to them on the left. Go to the right side of the bed. If they are demented, impaired, or let's say delirious, or lethargic, obtunded, and the patient is here, will be impaired. And when you stand there and they're 8 feet away and you're talking to them, they may not be able to pay attention. So I had this patient who was a 65-year-old man who had dementia, but he didn't realize it. He had no insight into it, and he was very upset that his family had taken him to see me, and they hadn't told him what kind of doctor I was. So when he learned that they were giving him all these memory tests before he saw me, he wanted to leave. He was agitated, and he was cursing like a drunken sailor. He was a sailor. So as I went in the room, he started cursing me. He got up to leave, and I said, "Just a second." And I said, "Oh, excuse me, Mr. Jones, what is this on your arm?" It was a tattoo. So he told me this night in 1948, he was drunk in Belgium and he woke up with this tattoo. And by the time he told me the story, he forgot that he hated me, forgot that he didn't want to be there because he shared the very personal thing. I mean, what could be more personal than which he lived with for the last 50 years. So everything was fine after that. This is just a issue of considering the patient's experience. So I have the distinction of having submitted a paper to the Green Journal of Neurology on the use of the rubber ducky in the neurological exam. The idea is the rubber ducky is very good for testing eye movements. Because some people will say, "Okay, look at my finger," and they look straight ahead and they say, "I see it, I see it." I say, I want to know if you see it or not. I just want you to look at it. No, I see it, I see it. So they don't understand the concept of I'm testing their eye movements. And you take out a rubber ducky, and without doubt, they will go look at that because they say, "What is the doctor doing with a rubber ducky?" So that way you can test up and down vision. I had another patient who was an older woman who was she came with her daughter and grandchild. And she was very upset. She didn't want to be there. She didn't like the idea we were just testing her memory. She thought there's no problem with that. And she had her granddaughter there, and the room was about 6. So I said, "I'll be right back." I came back with a rubber ducky. I gave her the rubber ducky to the granddaughter. I kept 10, 20 rubber duckies in my desk. And you can buy 20 of them for like $8. And as you notice, it's a doctor rubber. And the patient was completely overtaken by the idea the doctor gave a rubber ducky to my granddaughter. She just switched and became very cooperative and friendly. And she was so shocked that I had a rubber ducky, and our relationship was cured. And in case you're wondering, the paper was not accepted. But if you look at every time I do submit a paper to the Green Journal, it's there in the record that I submitted a rubber ducky paper 10 years ago. Similarly, when you're evaluating the patient's memory, you want to know what they think about it and what their spouse thinks. However, ideally, you should do that together as well as individually, because the wife may think he's demented, but not want to say that in front of the patient because that's kind of insulting. But then you get them in another room and they'll tell you that. But if you don't get them apart, this is another thing which it takes more time. We all have pressure with time, but you got to do it. If you want to know, are you depressed? And a man might not tell the doctor that he's depressed if he's in the presence of his wife, because his wife may think, "What do you mean, you ungrateful bastard? I cook for you, I clean for you, and you're depressed. You're not the one doing all this work." So they might not give you the right answer. In order to do it right, you have to do it in a separate setting as well as together. So another lesson would be to learn from your patients and learn about your patients. So we had a patient in Japan who had meningitis with salmonella. And the key question there was, does he have any pets? And yes, he had pet turtles. And turtles are known to harbor salmonella. We had a 52-year-old man and his daughter and his sister who both had pigmentary retinal degeneration, mental retardation, and cognitive disability. And he went to painting classes, even though he was legally blind and he couldn't see much, but he could see colors. And I couldn't find his paintings, but they're actually quite beautiful. And he told me, "I like to learn." I thought it was just so profound that somebody who has poor vision is painting and taking classes, even though has severe cognitive impairment. I think that's a lesson for everybody. Another illustration of how important it is to talk to the patient is this patient I had many years ago who had Parkinson's. And she said to me, Dr. Friedland, you know, I'm responsible for the use of amantadine treatment for Parkinson's. I said, oh, is that right, Mrs. Schwartz? I said, yes. I was a patient of Dr. Schwab in Boston. He was a Harvard neurologist. And I told him that I was taking amantadine for the flu, and my Parkinson's symptoms got better. So I told Dr. Schwab, and Dr. Schwab told me to get lost. You know, he didn't pay attention. So I went off of it and went back to him, and I was worse. And he didn't believe me. So I went home and I went on it again and came back to see Dr. Schwab. And I convinced him that amantadine was relieving my symptoms. And Schwab is the one who got credit for his paper in JAMA in 1969, the first use of amantadine for Parkinson's. And she said, and I agreed, that she should have been a co-author. If you fall off your motorcycle and you have an abrasion to your skin, it might be called a road rash. I'm not a motorcycle person, but it can be much more serious than that. And I know that because not too long ago, I fell playing tennis and I really wasn't moving that fast. But the contact with the clay court caused quite a abrasion, which took several months to heal. And I was just falling just like this, not going 30 miles an hour on the pavement. So calling it a road rash is an incredibly misleading minimalization of the reality of it. And the point is that the words we use influence how we think. So when Troy Aikman had many concussions playing for Dallas many years ago, everybody said, oh, Aikman had his bell rung again today. Well, the point of a bell is to be rung. The point of the brain is not to be damaged so much that you lose consciousness. So to call a concussion having a bell rung is actually a crime, or should be a crime. It's a misuse of language in order to misrepresent reality. And we all do this all the time, so that in regard to abortion, you may be pro-choice or pro-life, but all the framing of the issue is what's important. So the Ukrainians sunk a very big Russian ship many months ago. The Ukrainians said the ship was sunk. The Russians said ship is not floating properly. This is the official report from the Russian Navy. And I didn't make this up, but they didn't want to say it sunk. They wanted to. This is called a euphemism, where you find a way to minimize something. SpaceX had a rocket which blew up. I forgot, 60 seconds. It was supposed to last for 10 minutes, but it blew up. And you could see the explosion, of course. And they said it experienced a sudden, unanticipated disassembly. What a beautiful phrase. What a beautiful euphemism to represent explosion or getting blown up. But they didn't want to say that because it didn't sound good somehow. But this is just examples of how language influences thought. And the same thing is true for us. My most recent thought here is, we may all have a student who says, oh, hello, George. George is going to be shadowing me today. But what could be more passive than a shadow? I mean, it's really, really nuts to say some adult is going to do something as a shadow. It kind of implies that they're going to not ever do anything like ask a question, look something up, or go get coffee for something, even what, regardless. So we shouldn't ever say somebody is shadowing. On a deeper level, Today's Thursday, tomorrow's Friday. We all know what to expect on Fridays. We all have certain things we do on Fridays, maybe that we don't do on Sundays. However, I'm concerned that because we have a name for it, we don't realize that tomorrow will never occur again. We've never had a day like tomorrow, and we'll never have a day exactly like tomorrow again. So each day is completely unique, but we have a name. But the fact that we have a name is valuable. I'm not implying we can live without names, or without words for things, but they do cloud the reality of the infinite particularity of life. My favorite personal obsession is we shouldn't say rule out, because to say something's been ruled out means we have completely eliminated the possibility of it. And the false negative rate is never 100% or never zero. There's always some chance. If a patient has a headache and you do a spinal tap and you don't find any blood, that does not rule out the possibility of an intracerebral hemorrhage or intracranial bleed. So a friend of mine father was 95 and he had chest pain. He went to the hospital in Pasadena, California, and they saw him in the ICU, in the ER, and they did enzymes and an EKG. It was negative, but he still had the chest pain. They took him to the ICU, and he was all there waiting he was examined by the doctors, and they said they didn't know why he had chest pain until my friend called one of his favorite nurses who went to see him, who took off his shirt and saw that he had herpes zoster as a cause of chest pain. But they hadn't examined him. They hadn't taken off his clothes. I had a patient in the ER in Chinatown when I was moonlighting as a resident in New York, and a patient was stabbed in the abdomen. And I called an ambulance to take him from my emergency room to Bellevue. And when they lifted him off the stretcher in Bellevue, they turned him over, and he was also stabbed in the back, but I hadn't turned him over. I didn't know that. We've had some controversy here with the neurology residents, just that these two patients, a man and a woman, both had what might be autoimmune encephalitis. And cancer is a possible cause of autoimmune encephalitis. And of course, this is a very interesting topic for another day. But in order to evaluate that, you want to know if they have cancer. So we did a PET scan and a CT scan of the abdomen, chest, and pelvis, and it was negative. And I said, did you examine his testicles? And the answer was no, because he had a CT scan. Well, that's not right. Examining the testicles takes maybe 30, 40 seconds. And the false negative rate for the CT of the testicles is not zero. Similarly, they had not examined the woman's breasts because she had a CT scan of the chest. And similarly, there's no excuse for not, we're neurologists. Being a neurologist does not mean we forget how to listen to the chest, or how to examine the breast, or examine the testicles. So William Osler, the great Hopkins physician, said we should examine the patient in a good light and use our 5 senses. Look, we miss more by not seeing than by not knowing. Carl Menninger, who was a very prominent psychiatrist in America, said that physical contact with a patient is evidence of incompetence. And another psychoanalyst said physical contact is absolutely a taboo. This is the view of the 40s and 50s, maybe 30s, 40s, 50s, 60s, and is not current, is not correct any longer. So touching a patient may have a very great value in establishing good rapport and helping them to trust us. And it's not forbidden. sometimes if you have a good relationship with the patient, you may come to their room and hold them by the foot, hold their foot. And also the physical exam is an important part of this, of developing a good relationship. In 1990, I mentioned we had these 2 big grants in Cleveland, and I talked to the head of the neuropathology core and said, in our Alzheimer patients, are we going to examine the kidneys and the liver and the colon? He said, why should we do that? I said, well, has anybody done it? He didn't know. So it was discovered maybe 10, 15 years ago that there are Lewy bodies, which is a feature of Parkinson's, in the colon. But that was only discovered 10, 15 years ago. It could have been discovered 50 years ago. And this is complicated because there are various markers and stains which are not available, were not available then, which are available now. But aside from that, they could have found something wrong in the gut in Parkinson's if they had looked 50 years ago. But they didn't. If they had proposed it, they would have said, you can't do that. That's a fishing expedition. A great Rochester neurologist, Robert Joint, had a story where he said, anybody who criticizes research for being a fishing expedition has never been fishing, because when you go on a fishing expedition, you get a certain kind of bait, a certain kind of rod. You go there a certain time of day, a certain time of month, a certain type of year, and you throw it in a certain way, you collect in a certain way, and you do it. It's planned. It's not just. So I'm not saying that we should use every method to study everything possible because we're just fishing. But my thought is this Juno spacecraft that explored, I think it was Jupiter, they were looking to see what they could find. I mean, they had a hypothesis about the gases and the nature of the planet and so on, the core of the planet and the magnetic, but they were going to look for whatever they found. Why can't we do this in medicine? At least to some extent. Sometimes we don't do what we can for the patient if we can't help them. So I had a patient who had seen Robert Fishman, who was the chairman of neurology in UC San Francisco. He had Alzheimer's disease, and his wife said, I took him to see Dr. Fishman, and then somebody recommended you. And I said, well, what did Dr. Fishman say? She said, well, Dr. Fishman didn't say anything. So I called him, his office, a month after he saw my husband, and I asked his secretary if I could have an appointment to see Dr. Fishman again. And his secretary said, oh, Dr. Fishman said, your husband has Alzheimer's disease and you don't need to come back. Well, that is abandonment. So just the fact that there is no treatment, the new treatments, so it's another matter altogether for another day. But at least at this point, there was no treatment. Just because there's no treatment doesn't mean you can abandon the patient. And never give bad news like that over the telephone. And Dr. Fishman died of Alzheimer's disease. That is that's published in his obituary. He didn't appreciate what an important topic it was when he was alive. Much of what we are asking is outside the scope. Sometimes what is needed is to bear witness or be silent. So we need to be there with the patient. I found among the things that I could do which were most valuable to the patient, they knew that I would be there, that they could come back and see me again. And I would answer their phone calls. I didn't say, oh, okay, now there's nothing more I could do. Why don't you go home? And I wouldn't leave the room until they had asked all their questions. So I have said to some of my residents that I may have been negligent in not teaching them something. One thing I didn't teach them how to leave the room without the patient knowing that I was left, I had gone. Medication errors are a big problem. There is a case of a woman who was given haloperidol for dementia, for agitation, 0.5 milligrams, but the pharmacist gave 5 milligrams by mistake in the bottle, the bottle said 0.5, the pill was actually 5. Patient got worse. So what do you think the doctor did? Increased the frequency of taking the pill. Woman died. Another case, this was not my cases, but it's published. A woman was given anticoagulant in a bottle instead of a tranquilizer, and she died. It's not something we're going to consider, but you should, if you think of it, look inside the bottle. We don't think of poisoning that often, but there is a tragic case of Autumn Klein, who was a neurologist at the University of Pennsylvania, who died a few years ago, poisoned with cyanide poisoning, and her husband is in jail, found guilty of murder. But she came into the hospital with an acute toxic state, and whether the family is trying to kill the patient is not something we often think about, but that's something worth considering. At Mount Sinai, when I was a resident, a patient was killed because they gave intracarotid ethanol. There were 2 kidney basins, one with one with alcohol for cleaning the skin, and one with the radiation in the tracer, and they mixed it up. And I see I'm running out of time, but I want to recommend Introduction to Experimental Medicine by Claude Bernard. It's a magnificent book about thinking in medicine, and it's for sale by Dover, maybe $8. Always consider how the exam will contribute to the benefit of the patient. So is it help to know your genetic risk for Alzheimer's disease? There's nothing you can do about it that you can't do anyway. Even if you don't have the risk factor gene, the A4, you could still get Alzheimer's. So you should still do the good things that I recommend. Bengali poet said, "A mind all logic is like a knife all blade. It makes the hand bleed that uses it." So we should think rationally, but we should not allow our thinking to be limited to rational thought, because sometimes when you're riding your bike in the gym or when you're taking a bath, you may have an insight into something about a scientific problem or about your patient, because the mind works in a complicated way, which we, of course, don't understand. But it's not only when you're thinking about something that you're going to understand it. Even when you're sleeping, something's happening. In regard to bias, we all have different forms of bias. Some of them are unreasonable. Some of them are reasonable, so that if I was hiring a resident, if I was interviewing somebody for residency and he came in wearing a bathing suit, I would be biased against, okay, why are you wearing it's not. I'm biased against people who are so severely improperly dressed in a medical environment. But we need to be aware of aware of our bias. And one of my interests is this bias of the lost actors, or survivorship. That is, you don't learn from your patients if they don't come back. So you have to remember, whatever you've learned from clinical practice, you've learned from your experience, and your experience does not include the patients who went home and died, or the patient who went home and thought you made a mistake and went to somebody else and never came back, so you don't get that feedback. So Hillary Nelson died at 49 in an avalanche in a mountain next to Everest. She was skiing down and she triggered an avalanche. How unfortunate. And she's gone. So in my opinion, the fact that she's not here to write a book makes it hard for people who do these kind of things to understand what a horrible mistake it is. If there was a movie about her death in which she would talk about how she's missing her children, she's missing the fact that she didn't get to be 50, maybe it would be more apparent what a completely ridiculous thing it is to try to ski down a mountain like that. Okay, I will be happy to have questions in one moment, but this is my particularly favorite thought, that no single theory ever agrees with all the facts in its domain. And I was taught this by David Clark, who is a great neurologist at UK many years ago. He said, we're allowed to throw out one finding in each case, which doesn't mean that we won't consider it, but we shouldn't say, well, it couldn't possibly be Huntington's because there's no family history. That's not right. Or if you have an idea, it could be right, even if there's evidence that it's wrong. So in my experience in Cleveland and also at NIH, I would have a lot of ideas, and my bosses would tell me, oh, Friedland, would you stop it? You know, this is wrong because of this is wrong because of that. So Warren, who got the Nobel Prize for Helicobacter and peptic ulcer, along with Marshall, he just died like last week, and his obituaries in the New York Times. But they said bacteria cause ulcers, and they said, no, that's ridiculous because they can't live in the stomach. And that was wrong. But their theory was like rejected for over 20 years because they didn't understand that no single theory ever agrees with all facts in its domain. So if you have a new idea, if everything fits, somebody would have already done it. There is very important to remember a lot of things we know, like genes can be transferred from animal to animal. There are bacteria in the stomach. The brain is immunologically privileged. These things are all wrong, at least in part. But we've been taught it, and this can impair our thinking. So in order to be creative, we need to understand that truth is too complicated to allow anything but approximation. And a good example is Wegener, who's shown here, who died in Greenland. He said that it's continental drift. He was right. He died, and later they showed, yes, continents have moved. But his theory was rejected because nobody knew how could the continents possibly. They said, don't be ridiculous. That's a stupid idea. You know, continents can't move. But they can. So, but his theory was rejected because it contradicted evidence. And Sidney Brenner, who is a Nobel laureate from Cambridge, who worked with Watson and Crick, helped to define the mRNA and other things, won the Nobel Prize. He had a don't worry hypothesis, which I think is quite similar. He said, if you have an idea and it doesn't work perfectly, don't worry about it. Maybe that will all become apparent later. Finally, another lesson, you don't have to be brilliant to do research. I think many people think that the research requires a complicated level of thought, which is beyond you. And this is, think about Frank Gehry, who designed this building. I was shocked to learn he doesn't have a computer. I looked at this and I thought, my God, he must have some incredible computer capacities to understand these shapes in his mind. And he just throws them out and other people do all the work for him. Even if you're not good in math, it's not an important part of science. I mean, it's important, but the other people can do the math. Sidney Brenner said the best way to prepare for a heroic voyage in science is to start. And this video was put in this video. Brenner, who's no longer alive, said that we shouldn't be afraid of being wrong. And having an imagination means being open to ideas which appear to be wrong. And what's important is to have a free flow of ideas. Don't be afraid of saying something that's wrong. If you're on rounds and you're wondering about some patient, could they possibly have poisoning? Or could it be inherited even though the patient is 85 years old and has no family history? Don't be afraid of being wrong. Finally, in regard to the idea that you have to be brilliant, there's a story by the Buddhist teacher Jack Kornfield of a woman who had breast surgery, who was a singer, and decided because of this she could not possibly sing again. And a man came to see her who was a dancer who had lost a leg to cancer. And he danced. And she said, if you can dance, I can sing. I thought this is a powerful example of the fact that all of us are capable of doing research, and what we need in neurology is more serious answers to more serious questions. And we're all able to contribute to that, and to think that, well, I can't make any contribution is to underestimate the profound capacity of our imagination. And I'll be happy to answer your questions.